time to see the youngest guy in the snow, Francois Genet, and he will talk about forgotten muscle on deformities.
Younger guys, thank you. It will be necessary to make me think of complaining to the organizers of this Congress, who put my talk after that, Alberto. So, I will the idea to put this presentation for you because it's only my opinion of how we are all thinking about the deformity, and we are always only focused on certain muscles. Obviously, here there's a lot of people who think about other muscles, but I think in General Congress, the PMNR General Congress, we have to insist on that there is not only the triceps, not only the biceps, not only, and there is some really complex deformity, and sometimes we need to assess all the muscles that are involved in the deformities. So it's a real clinical presentation. It's not a scientific presentation, but when I read my titles this morning, finally, I should have said unexpected rather than forgotten. And this presentation is just for me the fruit of some situation in which I found myself that I needed the help of my little comrades, in order to solve this pattern that it's not seen obvious to me. So I prefer to write unsuspected muscle rather than, forgotten muscles. Quackel in 2015 had written in the Lancet Neurology that the selection of muscle for botulinum toxin injection also needs further investigation in a way that we have to find the target, and it's not so easy to find them. But as you know, maybe a few years earlier, Jan Bagulet, who is here, has also written this. And as you may know, there is no consensus as a discussion we have. It's obviously that. And it's one of the parameters hindering the evaluation of the effect of botulinum toxin on deformity and function, because we are not sure that the muscle we choose are the one really involved in the deformity or solely involved in the deformity. And there is a lot of sources of error. You can be attracted by a mirage, the most superficial muscle, for example, but is it the strongest? Is it the most voluminous? What is its structure? What are its antagonists or agonists? Is it in a strong position in the recovered deformity? The second source of error is relying on what everyone else is doing and the strengths of the habit and the transmission made to colleagues and students. Relying the regulation for drug authorization on label, injections, where you are on label, you are only injected muscles that are on the label, and maybe there is other one. And not question how we examine our patient, how is the joint above and the joint below, but mainly above, and making the distinction between retraction and hypertonia and one kind of hypertonia. So I would like just to present 3 examples. The first one, it's the 3 main situations. The first one is a deformity caused by many muscles. We all here have already talked about, the verticalization of the first metatarsal. The placement of the foot in the ground by the first metatarsal induces a lateral instability of the foot and the ankle. And you know that the muscles responsive for the vertical function of the first metatarsal could be the flexor hallucis longus, everyone knows that, the flexor hallucis brevis, everyone knows that, the abductor hallucis, now everyone knows that, but also the fibularis longus, and Philippe showed you this in this movie. When you have, we can clearly see that the pronation of the forefoot and the attack on the ground by the head of the first metatarsal can induce a lateral instability during the stand phase. Okay? So this is really often found now, and that's a way for us to inject, the fibularis longus. So we tried to show you this in a I had this patient who was a poliomyelitis patient who had no triceps and an hypertrophic, fibularis longus. And you can see when she put her right foot on the floor, she attacked the floor with the head of the first metatarsal, and she feel like an lateral instability like this. And it's exactly when you ask her to just to push on your foot, you see how it works. She does not have a triceps, but she has this muscle, which is a plantar flexor. But there is also, so this is what it was, a motor nerve block of the extensor hallucis longus, in my opinion, can also create this verticalization of the first metatarsal. When you ask this patient to create, you can see this. And this is, the link between the two muscles, which are above and below the first two. And you can see that this verticalization, when you are walking, can provoke, this lateral instability. So obviously, this is very, very complex, and sometimes we think so simply, and we have to think about all this, maybe this biomechanic situation. The second situation is the small and powerful muscles. We have already talked about the abductor hallucis. As you may remember, we found the motor branch with Bernard Parrat, and we can do some, motor nerve block of this branch very, very easily. You can do also, you saw it yesterday, intramuscular block. And when you do that, there is sometimes some strange thing, because it's, one more time, a little bit complex. Before the block, you can see the foot on the left, and after the block, you can see the foot, and you see that the horizontalization of the first metatarsal has induced a flexion of the distal interphalangean of the big toe by a tenodesis effect on the flexor hallucis longus. Because when the medial arch is going like this, it's straight on the flexor hallucis longus. Another type, which is really, really funny, when I saw this foot on the left, I saw there was a big, an echinus due to the triceps. So, but as there was also a verticalization of the first metatarsus, I did only the block of the abductor of the hallucis, and it reduced only by this block, which is an intrinsic block, the phenotype of the echine, with the possibility to put the heel on the floor. Obviously, you see that there is also a little, echinus. But you can treat an echinus, a phenotype echinus, by treating, an overactivity of a muscle which is an intrinsic muscle. This one, it's a it's a patient we saw, it was Tuesday. So we had this patient, which is an extrapyramidal patient who is walking like this. And we thought she was really, really annoyed by this extensor of the hallux. But basically, as there was not, tenodesis effect, we said, man, Philippe said, maybe that's the musculus extensorum digitorum brevis. And, at the first, we saw that we had to inject, the extensor of the hallucis longus. But basically, I think we thought that it was this one. And what is really, really interesting, that the fifth, two is not concerned by this muscle. And when we did the assessment, the fifth two is not moving. So it was a way for us to be to suspect this muscle. This was really, really funny. It was last Tuesday. Sorry. And so here I absolutely want to talk about polyarticular and superficial muscle, just to just give a little smile to Bernard. So here, there is, alors, sorry, before I absolutely want to tell you what a treasure trove the polio population. We had a short talk with, a short discussion with Alberto during a few minutes ago, because this population permits to understand the biomechanics and the functional anatomy. I see a lot of polio survivors, and every week I discover the ingenuity and the magical adaptation mechanism of the human body. And I'm going to show you two examples. First one, I put that breast to this polio who could not walk without. So he was very, very happy because he can stand on his lower limb. But he said, why my foot is like this? You know, like Charlie Chaplin foot. And we made an assessment to understand why. Basically, indeed, he has this deformity. And making the assessment, we found that the sartorius was a bit short. And maybe the brace is too in extension, and we have just to gain 5 degrees toward the flexion of the brace. So we did this, and the foot is going a little bit in the medial direction. So too much extension of the knee inside the breast, let's add a few degrees of flexion. So that's exactly the kind of reflection poliomyelitis survivors can give to you. Here you have a polio patient for whom we were unable to reload his left lower limb after a knee extension osteotomy and orthosis. The two legs are at the same length. Each compensation put under the foot induced a rise of the hemipelvis without the possibility of loading. So we put a lot of, under the compensation, and the hip is going like this. And it was not possible for him to put his weight on this left foot. So it was really, really bizarre. And Philippe de Normandie said, the hip abduction of the healthy side induced horizontalization of the iliac spines in the frontal plane, suggesting hypoextensibility of the tensor fasciolatae on the healthy side, not in the paralytic side. Wow, Joe. So we make a lot of assessment. It's a polio survivor. It's not a spastic patient. So how to manage that? So this is just to show you, but you understood well. This was for students. So when we, from this analysis, we were immediately interested in the tensor fasciolatae on the healthy side, which was indeed too short and induced this tilt of the pelvis under load. And when we ask the patient to put his healthy side in abduction where he's going on his 2 feet, it solves the problem considerably, and he could just a little bit, but release his appui, je sais pas comment on dit, his weight his strength, in his arm. So we have made intramuscular block with lidocaine is TFL, just to be sure that he don't need it for walking. We made it twice, and after that we have made the decision with Fabien, Bernard, and Philippe de Normandie to make a tenotomy of the musculus tensor fasciolatae. It was a distal tenotomy, I remember. Percutaneous, I remember, no? Okay. And so you can see here the patient before, And this one, sorry, I don't have, it was last week also. I don't have, but this one, it was 2 hours after the tenotomy, just 2 hours. And the patient said to us that he feels that now he's comfortable, and he feels that he can increase his weight on his left lower limb. Thank you for your attention.
Thank you, Francois, for this very interesting talk. We have to duplicate Philippe de Normandie and send one in every center, I suspect. Maybe with the progress of genetics, we can do so.
François,
This was Greenock Beginners.
François, bravo pour ta belle présentation, comme d'habitude. Je veux juste apporter de l'eau à ton moulin. Je rajouterais, sur le long fibulaire, souvent nous trouvons une hyperkératose sous, et c'est ce qui doit attirer notre attention, et surtout pour nos jeunes étudiants, en leur disant, quand tu trouves une hyperkératose, pose-toi toujours la question, pourquoi? Donc souvent on trouve une hyperkératose sous la tête du premier méta. Voilà.
François, in many cases, you present the foot with a cloud toes. Do you think it's a good indication of intramuscular diagnostic block, as presented yesterday by our young colleagues?
And I'm not very comfortable with intramuscular blocks, but it's because I do not practice a lot. I prefer motor nerve block because
Yes.
I'm well trained and really I think I feel more Belgium than French, way of thinking.
Yeah.
So maybe I'm in your part for this.
Yeah, but maybe an extensor hallucis longus muscle block, as a nerve is quite difficult to find, or extensor brevis muscle block.
Yes,
I don't.
for this one I practice intramuscular block, and it works obviously. But I'm not so comfortable. I'm not sure that it does not create some muscle injuries, and this is a point we have to discuss with Romain David and Poitier's team. It's because when you see, when you the literature about, the lesion in other, indication for injection of lidocaine in the muscle, we are not sure if there is some irreversible, lesion of the muscle. But I think Romain, I don't know if he's here. Yes, we asked him to make this, this literature review just to be sure that we can do it without any problem, because it's for me totally different to make one intramuscular of a muscle a day than if we ask to everyone in France or in Europe, you can do this without any problem. That's not necessary to make motor nerve block. And you are practicing on the same patient, I don't know, 20, 30, 40 injection of intramuscular block during these 10 years. We don't know exactly how the muscle will be. So I think we have to really to challenge this. And if there is some reversible, if it's irreversible, you have to think how to manage it. I think that's not so easy than motor nerve block, because motor nerve block, we have a long experience of the reversibility of the practice, the injection. But if you have, Romain, je ne sais pas si tu as quelque chose à ajouter.
You have certainly a myotoxicity with intramuscular block, but in the muscles of the foot, the dose is fewer than other blocks, peripheral nerve blocks. So I think it's a technique you should try, François.
Thank you. I will do it. I will do it. Thank you. You have to come to my office on next Monday, okay?
Okay, boss.
Another conclusion, François, would be if you're a strange case, something goes wrong, it's not logical, stop and examine your patient and think about every possibility within your team and to find a solution.
Yes, but with the experience, and here we are only with all experienced people, you feel now, that's very, very strange. When you are with Philippe or Bernard or with you, when you see a patient working, you feel that that's not so simple. There is something we have to, and you have to do to perform the clinical examination before practicing the motor nerve block, I think. and there's a lot of things you can see and you can feel and you can find only with a clinical examination. You have in my opinion, you have to be very, very careful on what position is your arm when you, or your limb, sorry, when you are examining a patient. When you are examining an ankle, how is the hip? Is anybody, because if two people is going to make an exam of an ankle, you have to be all in the same position, and maybe sitting, lying on the bed, and mainly standing up. So that's really, really important, and that's why when we have interns, we are making, their report at the end of a consultation. They say, okay, the range of motion of the shoulder is ta 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 ta. No, the range of motion of the shoulder in this position is da-da-da-da, but in the horizontal plane, in anatomical plane, in functional plane, lying on the bed, etc., etc., etc. I think that's not possible to write some range of motion without describing how the patient is in position. I think that's really, really important.
Another good reason to take video, because yes. I don't know your expertise, but sometimes you met a strange case and you remember, we already met such case 10 years ago, it was Mr. T, and you look at the video and what you did as a treatment.
Yeah, when you see an examination of a shoulder by Bernard, with reflecting about how the fibers are, and so that's totally crazy. You spend, I don't know, half an hour just for one shoulder, but at the end, he knows exactly what is the problem. And I think it's really, really important. Spend time to examine your patients. But I think everyone knows that.
J'ai une question, enfin pas une question, une petite remarque, ici. Quand on s'intéresse au premier rayon, en fait, parce que tous les muscles que tu as décrits pour la verticalisation du premier rayon, en fait, et qu'on en déduit que c'est une instabilité, enfin l'instabilité externe liée à ça, dans beaucoup de situations du patient normal, la verticalisation du premier rayon, ou en tout cas quand on recherche à stabiliser, c'est un manque de stabilité en interne qui induit ce blocage de degré de liberté et qui secondairement fait l'instabilité en externe. Et donc il faut rechercher l'objectif de cette verticalisation du premier rayon pour savoir s'il est nécessaire ou non de la régler. Parce que parfois, régler une déformation qui est utile peut poser ce type de problème. Donc c'est la limite de la lecture d'instabilité qui est secondaire à cette stabilité initiale recherchée.
Yes, the difference is that, but okay, totally agree with you. And I think we need to think that what is the complaint of the patient, because the first thing you have to do is to reduce the complaint or to solve the problem, because this is really, really important. And that's not, I totally agree. The deformity you see in first, that creates the real problem, but it was just a way to make a picture on the reflections. That's all. I totally agree with you. Obviously, you know.